on. So it is a pleasure to be here. Right now, I'm working at or for, depending on how I feel during that day of the week, in Northwell Health System. That's slowly spreading like a blob across Long Island in New York, specifically at North Shore Hospital. And at least in the Long Island region, I function as the director of inflammatory bowel disease. Sounds grand, but like so many things in the system, it isn't so grand. It's pretty much me, my nurse practitioner, a research coordinator for clinical trials. But inflammatory bowel disease is my specific sub-area of interest within GI, and going to be the subject, or at least part of it, of the talk. Not to apologize for the talk I give, but the talk's going to be broken up into three sort of distinct parts. Probably for those of you who are spending most of your time on the hospital service, it's the last one that'll be the more interesting. The first two parts are maybe a little more outpatient oriented, but of course all the patients you see in the hospital, they're not here forever. They're passing through, and even if you're not doing some of the outpatient directed care or managing these issues that I'm going to be talking about, it's still a good time while they're in the hospital to check in on these things. I know even as people are admitted to, our hospital, even things that you think of as outpatient management, vaccination history, particularly during flu season, did you get your flu shot? Have you had a pneumonia shot? So even though, the hospital world and the outpatient world seem separate, they're not so separate because, hopefully people are spending relatively little time here and more time on the outside. Whoops, wrong way. So the topic of the lecture is, filling in the gap, and again, what do I mean exactly by filling in the gap in the care of the IBD patient? When somebody comes in specifically to the hospital or even to the office with inflammatory bowel disease-related issues, be it diarrhea, abdominal pain, weight loss, all the things we typically associate with IBD, there's a tendency, not just, among internists, but gastroenterologists, everybody, even the patients, to sort of, I don't want to say ignore, but sort of neglect the fact that it's really not just a bowel disease, but it's truly a systemic disease. We see not just bowel manifestations, or sort of those traditional systemic manifestations we all learn about in medical and nursing school, the arthritis, the skin rashes, all these things, but also, those are fairly obvious. Those kind of leap out off the page at you. It's the things that you're not thinking about, that you're not seeing, where your patient, these days is going to get burned. And I'm going to talk about these issues, these sort of other, not so hidden issues relating to the IBD patient. And of course, even if the disease is primarily GI located, still and increasingly the medicines that we use to treat inflammatory bowel disease are themselves systemic medications. They aren't, except with one or two small exceptions, not localized to the bowel. So there's things you have to, again, think about that whole patient in the management, so you don't, deal with any unnecessary complications from your treatment. Why are some of these things being missed? A lot of the issues I'm discussing are sort of at the interface of internal medicine and gastroenterology, and that's a tough place to have a problem. If you're, because again, a lot of these issues are not being seen or dealt with as commonly by the internist, so may not have the awareness of these things as a problem that I'm going to talk about. And for the gastroenterologist, even if they're aware of these sort of ancillary issues, they may, most people don't go into gastroenterology to deal with primary care, what is perceived to be primary care issues. I'm going to introduce these topics in a second. So again, the gastroenterologist, they say, yes, I'm aware of these things, but I don't think it's my responsibility to deal with, which is okay as long as you reach out to the person and get somebody to take responsibility. There's often poor awareness, poor communication, and even at that, even within the GI community, there isn't universal awareness of what some of these ancillary issues are. So, without further ado, I'm sort of tiptoeing around the subject. The things we're going to talk about today, probably in increasing order of my own personal interest in the topic, is bone diseases related to inflammatory bowel disease, vaccine preventable illness and infections, and what to do with an immune patient or a patient who may become immune suppressed through your treatment, and some of the vascular complications, particularly blood clots, VTE, and pulmonary embolism. Again, that's something that may be more interesting and relevant to you here in the hospital setting. That patient walks into your office, my office, hopefully my office, or anybody's office. You're going to be thinking, you're going to look at her, and you're going to almost assume she has osteoporosis. You're not going to think twice about testing her, talking to her about it, potentially treating her. That's sort of sort of obvious. The problem is, the IBD patient, at least coming into my office, is going to tend to look more like this. Even in between periods of illness, they're going to be, still, the active IBD patient still skews to a little bit younger. They're generally in between their, bouts of disease. They're very active, so you're not going to look at that sort of person as somebody who may have, bone disease and even significant bone disease, be at risk for pathologic fracture, but they are. And that's the take-home point. They are. And you got it. And again, if you're not proactively thinking and looking for the problem, you're not going to find it until they break something, and then it's like, oh, I wish I had checked. Just some numbers again. We know osteoporosis is common in the United States. We know, sort of different prevalence between, different, ethnic groups and lifestyle factors. Somewhere roughly 9% in the population over age 50. In the IBD population, just as a just to throw numbers out at you, it's going to be somewhere between 50 to 100% higher in the IBD population. So again, that's, per any age, all across the board, from the older patient to the younger patient, they're going to have just, roughly to remember, almost a doubling of the risk, again, skewing more towards the Crohn's patients and the ulcerative colitis, but all of these patients. Again, the complications, again, as we sort of test and work up these, did I go past the mechanism? Which way am I going? Oh, I'm on the wrong way, sorry. One extra, that's me, okay. Again, the osteoporosis, and as we measure, it's not just the numbers, not just the diagnosis, and if somebody's bones were thinner, okay, that would just be something interesting to diagnose on a test. But of course, osteoporosis, osteopenia is associated with fractures, and again, just so you can see where some of these numbers come from, in this country we're not as good at large database. We have the different hospital systems and private practices, but in places like Canada, you see the study from Bernstein, this is in Great Britain, they are tracking at a much larger level, outpatient practices by disease diagnoses, and again, you could see here roughly in the relative risk is, about a 50% increased rate in fractures related to osteoporosis in the IBD population, again, skewing more towards Crohn's disease. What's the etiology? The disease itself is a problem. Again, particularly with Crohn's, we talk about, malabsorption, maldigestion, certainly in either disease when the disease is active. As I say, with inflammatory bowel disease, even though most of the complaints are within the bowel, it really is a system, all these inflammatory mediators, they don't just sit in the bowel, they tend to circulate throughout the body, and they can, impact bone health. The reality is probably more than anything, the major factor leading to bone disease in the population is our own treatment of the disease, and when I say our own treatment, we're talking about corticosteroid therapy. Again, just on the outpatient side, you may think of it as just an inpatient phenomenon. Somebody comes in, they're sick, you give them steroids, Solumedrol, Prednisone, which is appropriate, by the way. This is not inappropriate management, but that's also occurring on the outpatient side. At any given time, and this has been looked at in several different populations, surveys, large referral centers, community practice. At any given time, you have about 10% of your IBD population on some form of steroid therapy. So that's at any one moment. Never mind the other 90% is a good chance, half or more of them have had steroids at some time in their disease. But again, not just the steroids, diminished activity related to disease. Crohn's disease patients still tend to be more likely to be smokers, which can also impact bone health. But again, to beat the dead horse for a few more seconds, steroids are, they're in, in a lot of ways, they're the perfect drug for acute inflammatory illness of all sorts. Certainly with IBD, I mean, it's, you're stunned if you give somebody a good hefty dose of steroids and they're flaring, you're actually stunned if in a day or two they're not miraculously better. It's that kind of response, and we still see that, and that hasn't changed. Thank you. But they're also, as much as they seem to be perfectly designed to control acute inflammation, they're also almost perfectly designed to destroy your bone. It is a dose-related effect. They inhibit formation of bone, they stimulate destruction of bone, decrease intestinal absorption of calcium, increase urinary urinary loss of calcium. So again, if you wanted to design a drug to thin your bone, you really couldn't find anything better than steroids. And again, this is going to be sort of a recurring theme through the next two sections. Why do I call this a gap? Again, you could see this is a survey, actually very well and atypically well-responded survey of 1,000 gastroenterologists. 300 responses is a tremendous response in any sort of survey. Very few, or half of those, were aware of using their own society's guidelines about management of bone health and IBD, and there are, gastroenterology, bone health management guidelines, because this is such an issue. And, this is the real problem. This is why I bolded. 34% felt that the bone issue should be managed by another physician, which may or may not be true. There may be another physician who is willing and able to help you manage the patient. But again, if you're prescribing these sorts of medicines, if this is your patient, you have a responsibility at some level to make sure that they get the necessary, workup and treatment that they deserve. Again, prevention, of course, should be number 1 through 10 on the list is limiting steroid use. This is about half the time in the office is talking to my patients, convincing them to get off their steroids, talking to them about the role of transitioning to something a little less toxic long-term, treating, of course, with non-steroidal medications, checking vitamin D levels. That seems to be, I don't know how much you do that on the inpatient side, that seems to be the craze du jour on the outpatient side of medicine. It's associated, it seems to be associated with everything. The causality of vitamin D with all of these disease states is a little sketchier, but you'll still find, broadly, not just for the IBD population, but, in the general population and those with osteopenia, osteoporosis, these recommendations for vitamin D and calcium supplement. Again, how strong that benefit is, that seems to be a little iffier. Smoking is still a bad thing. Again, diagnosis is not any different in the IBD population. We're still talking about DEXA scans, even in younger patients. Again, just broadly, these are some of the older guidelines. Remember Dr. Katz, Zainab? Yes. Remember him fondly? So he's one of our national IBD mavens, wrote these guidelines. These are, actually quite old guidelines. They're only recently, updated in part, but they talk about checking all IBD patients over the age of 50, anyone with ongoing corticosteroid therapy, and anybody with a cumulative 3 months of treatment with steroids. That's a majority of my practice. So, somebody walks in, even if you've never taken care of them, it's a first visit, and people do tend to move around, and, insurance has changed. I always ask about steroid use. Have you been hospitalized? Have you used steroids? And any, at least at that time of that writing, any 3-month block of steroid use was considered significant enough for a lifetime of checking for bone health. And again, this is not a minority, this is a distinct majority of patients. Frequency of testing, they were a little vaguer in their own guidelines, because they don't know. Some recent update may be a little more conservative, talking about, upping the age of testing, but again, very specifically, low threshold for testing anybody with any history of corticosteroid use. And again, there were 3 months use of, a course of steroids in an IBD patient. That's pretty typical. We're not talking about a disease if it's going to at least have initial response to steroids, they can give a week or two and then stop it. Sort of traditional management is you give a high dose for a couple of weeks, and then you can be into a 2 or 3 month taper. That's very, very common. Specifically, they say, a cumulative dose of 7.5 milligrams per day of prednisone for greater than or equal to 3 months. I have patients, unfortunately, have been on doses like this, for months or years, So this is, again, this is not, some sort of, uncommon, problem. This is something that's literally walking through the door every day. I've been asked at other times giving talks, because I know sometimes you get, even if something seems like a good idea and you can show a guideline, is there any insurance pushback if you're ordering a DEXA scan on a patient who's 30 years old? I'd say, years ago, I found that there was a little more pushback. I don't think the people in my office who are doing the authorizations are any better than anybody else's. But generally speaking, we're not, if you code it properly, IBD diagnosis, we're not getting a lot of pushback if you want to order the testing. So, so give it a shot. Again, not something you'll be doing in the hospital. I haven't had the scan done myself, but that's supposed to be a DEXA scan in process. So that's much less invasive than most of the testing I recommend to my patients. They're generally relieved if I'm not offering a colonoscopy. They'll sign up for the bone scan. Again, diagnostic criteria the same for the general population. I think you're all, sort of maybe getting chills thinking back to the boards in terms of Z-scores and T-scores. Basically, it just means your bone is very thin. The treatments seem to work as well, and that's important too. Just because you have this, a similar disease in the specific population, do the same things you use in an 85-year-old woman, do they work in these tend to be younger IBD patients? The answer is yes, particularly with the biphosphonates. Again, non-steroid therapies for IBD, these sort of TV commercial medicines you see advertised, the Remicades, the Humiras. There's even studies showing that they can improve bone health, again, largely through disease control, not through a primary bone effect. But, the sort of the mainstay therapy, the biphosphonates, they also work in this population. So, again, maybe not something you're prescribing so much here in the hospital, but something, to be aware of as your patients are transitioning out, especially if your name's on that steroid script. You may want to have a couple of words with them to remind them about that. Gap number 2, that's not me. So we're increasing, at least in my order of my own personal interest in the topic, is vaccines, and there has been, traditionally there's been a lot of confusion despite, again, numerous published guidelines from the federal government, from professional societies about, use of vaccines in the IBD population. There's even been concern by some voice in the past that giving a vaccine may actually trigger the onset or recurrence of disease activity. That does not seem to be the case. I think the greater issue is the safety of vaccinations and the persistent confusion about which vaccines are safe, particularly in patients who are immune suppressed. And again, what defines immune suppressed? Are all these patients immune suppressed? What's the right timing? What are the safe vaccines to give? So again, there are plenty of guidelines out there, so don't be shy. There's specific IBD, general immune suppression guidelines by the Centers for Disease Control. And again, as I said, there's really very poor compliance sort of nationally, with the guidelines. Again, same issues as there's sort of a knowledge gap. People, physicians don't know or investigate as much about they should. And again, even where there is awareness, you see the internist pointing the finger at the gastroenterologist pointing the finger at the internist. I don't give vaccines in my office, but again, I do know, what is appropriate and what is safe, and it's my responsibility sort of to harass the patient until they get back to their internist's office, and if they don't have one, to find them one, to take care of these things. But again, sort of communication is key. You can't just, I don't like, and I've never heard the, tell your internist I said this is okay. That's not a way to communicate, with another doctor. You pick up the phone, or if you're very busy, give a little letter, patient is clear for these vaccines, they're appropriate, and sort of take it from there. There's a favorite quote of mine from one of these review articles. Again, it's a dual responsibility, as I mentioned, between the primary care doctor and the gastroenterologist. And a line I agree with, physicians who accept the responsibility for prescribing immunosuppressive therapies should be familiar with the guidelines and educate the patients appropriately. That's sort of self-evident, the same way as, I just talked about with the bone health. If you're going to be prescribing, steroids, you can't just give it and sort of divorce yourself of some of the even, long-term consequences of these. You have to be involved in some of the non-GI issues that should arise. With the IBD patient specifically, though, it's not even just dealing with the patient who's immune suppressed. Now, you also have to look at any patient, even if they're looking well, and even during a well visit, and think, okay, this is somebody who may be potentially immune suppressed in the past. So it's not enough just to deal with what vaccines they need now if they're immune suppressed and what's safe and not. You have to look at everybody as a future immune suppressed patient and say, what do I need to do for the patient now to protect them in the future? Is there anything I may have an opportunity to deal with now that I won't have the opportunity to deal with safely in the future? Again, another favorite survey, not surprised, only 14% of gastroenterologists, seeing IBD patients will even take a vaccine history. There's very low awareness of the risk of live vaccines. And very few of the patients, who were surveyed, again, this was a combined physician and GI survey, said they received any vaccine talk or information from their doctors whatsoever. Here's a particularly scary one. This is another, this is more appropriate survey response, about 1 in every 10 invitations for the survey. Only about 30% of, and these were, to a large degree, patients seeing a fair IBD population, around 30% of the gastroenterologists would actually recommend live vaccines to the immune-compromised patient. That is a decidedly bad idea. There's black box warnings if you care to look up for, most of these medicines. So again, we're seeing, a combination of a little bit of a passing the buck and also just sort of an overall lack of knowledge. So, how do you make this simple? How do you make this simple? Vaccine basics. There's inactivated vaccines, which are, at any point, theoretically, not just theoretically, it's been shown, any point are safe to give your patient, even if they're on high-dose steroids, even if they're on Remicade, methotrexate. You can see the inactivated vaccines, A and B, Gardasil, influenza, pneumococcal. I'm going to go into that in just a second on the next slide. Meningococcal vaccines, and then the live vaccines that may not, I say may not, are generally not regarded as safe in an immune-suppressed patients. Easy enough to remember, MMR and chickenpox, right? MMR and shingles, varicella. Those are your live vaccines. So even if you don't have to remember the safe list, you got a much tighter, unsafe or questionably safe list for a patient who's immune compromised. Again, as far as the safe vaccines, again, these patients, it's not only safe to give them flu and pneumonia vaccines, it's actually necessary. Immunocompromised, and perhaps even if they're not immune compromised by medications, they do seem to be at higher risk for the flu, for pneumonia. Remember, even when they're not on immune-suppressing drugs, these are individuals who do have an immune disorder at some level, so that there is some background increased risk, even regardless of the medicines you may be giving them. Cervical cancer, cervical dysplasia, is actually higher in the IBD population. Again, probably more related to medication treatments, probably more to the older treatments, which are still in use, the azathioprins and the 6-MPs of the world, rather than, again, my TV commercial medicines, the Remicades, Humiras. But it is still at high risk. So again, I don't know, what the uptake has been in the community for the sort of recommended universal vaccination of females 9 to 26, but certainly the IBD population want to get these young women vaccinated and continue with the PAP screenings, of course. Again, then we get into the necessary but not always safe. As I told you, MMR, varicella, herpes zoster, which is basically just a different strength of the varicella vaccine, not safe of immune suppressed. And what's immune suppressed? Again, not expecting anybody to memorize the list other than to be aware that it is out there and it is searchable. It's patients on Humira, it's patients on Remicade, it's patients on 6-MP, it's patients on patients that you would probably already be a little scared to vaccinate. You should be. But again, just remember the context of what is safe and what is not safe. What you may not be thinking about, sort of the first one on the list, again, and this is immune suppression, are corticosteroids. Patients on active corticosteroid therapy, even in those who are off steroids for weeks or months, can still be regarded as immune suppressed. And that's the one that we tend to forget, because we think of, prednisone and corticosteroids as anti-inflammatories, to which my patients will say, well, then why don't you just treat my disease with Motrin or Advil, which is actually a good response. The reality is, while they have an anti-inflammatory effect, and it's very interesting. I put together a slide for the fellows. Put together the slide. I stole it from a New England Journal article. When you look at the mechanism of action of corticosteroids, they have multiple levels where steroids act against inflammation, but they are profound immune suppressants, and they actually act at the level of the cell nucleus, in your body's white cells. So we're talking about, in many ways, as profound an immune-suppressing drug, again, as those medicines you see on TV, and one to be respected. Significant protein-calorie malnutrition, again, hopefully you're not seeing too much of this, but if a patient, BMI is 15 or lower, and I have patients like this, you may want to get, as much as you say, oh, I'd love to give you, update your vaccines, you may want to, see their health improve before doing that. Again, there's the sort of concept of low and higher level immune suppression. I wouldn't concern myself too much with it. I wouldn't split the hairs on what's the dose of the azathioprine or what's the dose of the 6-MP. If they're on the medicines, you can just, in my opinion, you can just forget about any live vaccines. Interestingly, also, as putting this talk together, of course, accidents do happen, and sometimes accidents are a good way to get some interesting data. As much as if you, anti-TNF drug, that, by the way, that's again, Humira, Remicades of the world, you see these commercials endlessly run. There have been patients who haven't been vaccinated, and I think there's a specific study with, yes, with zoster vaccine, they did a search of some large insurance claims database, and they actually found 633 patients actively on immune-suppressing treatment who, presumably by accident or negligence or whatever you want to call it, did get vaccinated to zoster. Pleasingly, interestingly, none of them developed zoster, which is nice, and they did seem to reap the benefit of decreased rates of zoster over the past 2 years. Again, this is not an endorsement to ignore the warnings on the package insert, but just sort of more of an interesting digression in JAMA, pretty good data. Newer medicines, just again, briefly, have you started seeing the TV commercials for this one? Entyvio, vedolizumab. It's actually a very interesting drug. Sort of very exciting. Certainly when it came out, I think it's 3 years now that it's actually been approved. TV commercials only been approved for 8 months, and this is not quite, as much as we talk about these as systemic medicines, and of course this is this is given by an intravenous infusion. Once you settle into treatment, it's every 8 weeks of therapy. But what's interesting, it doesn't sort of block a specific immune mediator throughout the body. It blocks the migration of activated white cells more or less specifically, to bowel mucosa. So you sort of, the bowel is inflamed, it's sending off signals to recruit more white blood cells to perpetuate the inflammatory process. This sort of blocks the ability of the white cells to sort of get off the train and at the stop of inflammation. Again, so this would seem to be very bowel focal medicine, maybe doesn't have the same risks in terms of live vaccination. Again, here I'm talking, you're looking at it, live vaccine should not be given concurrently. Again, I mean, this is not, you can call this ass covering by the drug company, but it's really, it just hasn't been, tested. The vaccines haven't been tested in this population. So there's just no data to endorse, safety or lack of safety. And again, where you have a gap in that data, I would suggest, doing what the box tells you to do. And even newer, though, well, I say newer, it's been out for a while, but for Crohn's disease, it was approved just within this past year. You see the Stelara commercials for psoriasis. This is, again, now approved for Crohn's disease, rescue therapy in patients who have failed other immune modulators, immune-suppressing therapies. And again, the same warning, again, you're really not tested in this population, but I would be cautious. Again, this is more for the office practice, certainly, than the hospital. Patients come in, I must admit, I don't take or attempt to take anything like a detailed vaccine history. I just test them. I just test them for whatever vaccine, measles, mumps, rubella, varicella, hepatitis B, and if they need something updated, and if they can be updated, meaning they're not currently immune suppressed, I make sure I send them and we get it done. If somebody comes in and they're already on steroids or they're on Remicade or Humira, honestly, I don't even bother testing them because it's just a waste of time, it's a waste of money. You can't do anything with that information. But again, even the immune suppressed deserve and need those annual flu shots, the pneumonia shot that's not annually. Okay. I couldn't find a snappy slide for the last one, and maybe the one that's most relevant. Yes, sir.
Sorry to interrupt.
Yeah, no, sorry.
At what age should long-standing IBD patient get their first pneumovax? There's other immunosuppressed A20 people, that we give them.
Yeah. I don't believe the guideline. I think, again, because they're either immunosuppressed or they're on their way to being at some point in their life, presumptively. I don't think the guidelines specify an age. I think it's just vaccinate. I believe so. I won't say I'm for sure. For the flu, it's definitely just vaccinate, and I believe it's the same for the pneumovax. And the pneumovax, I think I zipped past it pretty quickly. There's there's a single and the bivalent. Is that the proper term? It's a broader vaccine. It's
the Pneumovax, which is the
Pneumovax.
3-valent, and the Preventable, which is the 13-valent.
Yeah.
That's the one that still I've never seen it. That's 65 and over only, no matter what. So Pneumovax is anybody. It's plenty of high-risk individuals, but
again,
are 65 and over.
You definitely want to regard these patients like you do that older patient. They are that high-risk patient. Again, going back to the slide, guy on the mountain, he doesn't look like, that sicker patient, but, he is, at least in these, very specific ways, he is. Last but not least, my personal favorite, or one of most interest academically, is the risk of venous thromboembolism. Again, I apologize, this is a slide that was for more of a community talk. I know you all know what thrombus is and you all know what embolus is. It is still, unfortunately, even with all the emphasis on prophylaxis, it's still, we've all seen cases of VTE and embolism, still very, very common. Maybe over 100,000 hospital-related deaths. This is not IBD deaths. Hospital-related deaths annually occurs in about 5% of untreated at-risk patients, and about 5% of embolic episodes can result in death. And again, last line relevant to the talk, IBD patients fall into that highest risk category for VTE. Again, the absolute risks, are low. It's again, we're dealing with an issue of relative risk, and again, without dwelling on the different databases. And again, we see the Canadian database, and we'll see the British database. You're talking of a risk of about 3 to 4 times that of age-matched controls, and basically the IBD patient. And this is critical. Remember, again, they don't look, they don't look like your typical at-risk patient with congestive heart failure. They don't look, hopefully aren't a malignancy patient, but actually, again, and this is more specific to the inpatient setting, though it's also true for the outpatient setting, that hospitalized IBD patients have rates of VTE, comparable to those cancer and congestive heart failure patients. Don't have the orthopedic information, but they're every bit the sick medical patient that these others are. The issue, and again, for once we see an American study, again, showing the same thing, highest risk in IBD patients hospitalized, maybe a little bit more for ulcerative colitis, and even more so in the younger patients, maybe because they tend to come in, sicker than their older counterparts. There's even some concern that embolic events in this population, again, can't provide any reason for this, and this is only one study, that you may even see, higher rates of complications related to VTE than you do in the older population. Again, the risk factors, just going through it briefly, IBD disease activity is the main risk factor. So an outpatient with quiescent disease has really very little to no increased risk. IBD outpatient with active disease has further increased risk, and then the highest risk for thromboembolism is the inpatient with IBD inflammatory activity, particularly those confined to bed. Importantly, there's never been shown to be any associated separate hypercoagulable disorder in these patients. It is the disease itself that promotes thrombosis. Again, cigarette smoking, we see a lot of younger patients who are on oral contraceptives, and of course, hospitalized patients tend towards dehydration, immobilizations, IV catheter. Sort of getting to the heart of the issue, again, here are the guidelines that the American College of Chest Physicians have endorsed pharmacologic prophylaxis in these patients, as have the GI societies, so they get a little bit vaguer, patients with severe colitis, those confined to bed, what defines being confined to bed. But you see this across, guidelines in Europe, Canada, the United States. Again, the problem is, of course, sort of that cliched slide, again, they don't look like the other patients in the hospital. The real issue, I think, is that, of course, when somebody comes in with an IBD flare, there's a very good chance they're already anemic. There's just as good a chance that they're actually bleeding or seeing some degree of blood loss, and it can be a very hard sell to tell somebody, oh, you're at risk for this potentially catastrophic complication. Well, what do we do to treat that? Well, I'm going to give you a blood thinner. It's like, oh, I'm already bleeding. What do you mean you're going to give me? No, I'm trying to prevent this other worse thing. I can always give you blood. And the reality is, as much as the professional societies endorse, this strategy, there's not a lot of evidence on the safety. We looked into this, actually. That's why I said it's my own research interest. And, we pulled data, again, that's, one of the nice things about being in a large system, you can get these large data pulls or data dumps. And again, I didn't include the number here, but we looked at over 800 IBD admissions over 4 hospitals, community, and the academic hospitals. And no surprise here, we saw that patients with severe disease who are getting the PVTEP, that's the pharmacologic prophylaxis, that they actually, you do increase their risk. This is not a bleeding. You can't retrospectively go through every note and say, okay, were they bleeding, how much? It's very difficult to quantify. It's impossible to quantify. But you can see what their transfusion events were and their chance of being transfused. And you can see you have roughly a doubling in the risk of transfusion if you do what the guidelines say you're supposed to do. How do you package this to the patient? Again, there's no absolutes. I mean, if somebody's having their 5th or 6th unit of blood, hung that admission, maybe this is the one where you really can't do it. I would assert that, so many of these admissions in these patients anyway require some blood transfusion. That's so all admissions for IBD, about 11% of those patients took a transfusion, that you have to tell the patient, I want to sell, but tell the patient, we have to incorporate the idea that you may need a transfusion into just sort of your process of care. That, again, we can give you a unit of blood, but going to the ICU and having a life-threatening event, these are the things we're trying to prevent. But again, there's very little data on the subject, but the reality is, you have to be honest with your patient and say, yes, we may be increasing this risk, but this is something we can control. And again, something, that the patient, certainly they're scared to see blood, and even the managing physician, even the gastroenterologist, the bleeding of IBD, it's not like an open artery, it's not an ulcer bleed with a visible vessel, it's more, the mucosa weeping or leaking. Patients do not exsanguinate, with colitis bleeding from being put on Lovenox or heparin. So again, themes of the talk: shared responsibility, talk to your colleagues, make sure, you identify the issues and that somebody takes care of it. Know that there are guidelines out there for good or for worse. Guidelines mean you have a place to look for guidance. Guidelines also mean that somebody's written about it. They've written about it extensively, which means you're responsible to be aware of these things and to implement them. And always do the right thing for your patient. Thank you very much. Please.
What's the risk for an active IBD patient in the community for developing clots or emboli? Is that how much greater than the general population?
Again, I don't have it is greater, and interestingly, the data that's looked at is while the guidelines focus on treating the inpatient because they do have that highest risk. Again, theoretically, they're sickest, they're pretty much lying in bed most of the day. The absolute risk is highest for the inpatient with IBD. The relative risk, so that largest jump, is actually in the flaring outpatient. Again, without giving you the exact number relative to the general population, it's still they've done mathematical modeling, cost benefit, because there are risks to giving anticoagulants. I don't want to brush those aside, but it's basically generally regarded that the costs and the risks, at least on the outpatient side, are still heavier than the risks of having an event. That said, again, people come into my office and I almost do these things unconsciously. I think we all do who see a large volume of patients, heart, lungs. You squeeze the legs. People ask me, they're in a GI office, what are you looking for? And the honest answer is most of the time I don't even know what I'm looking for. I'm just sort of going on automatic. But in the IBD population, they come in, you throw them on the table. Okay, their belly hurts, they're complaining. I mean, if you have a unilaterally swollen leg or new leg swelling, even bilateral, I mean, that's something. So yeah, it does occur in the outpatient setting. You still have to think about it. That's a long, circuitous way of saying I don't have an exact number for you, but it's still an issue. But there's no recommendation to actually prophylax.
Other than the risk of increasing GI bleeding, is there a role for low-dose aspirin? You mentioned sticky platelets and all that.
Yeah, no, again, in any one individual who's to say, certainly, particularly my older patients, enough of them are on aspirin anyway, never mind these sort of endless debate about whether aspirin itself can, trigger IBD flares. I'm not 100% sold on it. But aspirin as a DVT prophylactic agent, to the best of my knowledge, has never been shown to work. That's why, patients coming into the hospital, that's why they get, the heparin, the Lovenox. I know people say, oh, I'm going on a 12-hour flight to Hawaii, I'm going to pop a few aspirin. I'm like, okay, I mean, it's, good luck. I don't, doesn't really, it seems like it would work, but it doesn't. You're all awake. Thanks. Thank you very much. You're welcome.